In this video, I have chosen to focus on a skin assessment tool as well as a management tool for skin integrity. For my assessment tool, I will be looking in depth at the Braden scale and how to properly utilize this in collaboration with our daily head-to-toe skin assessment. For my management tool, I will be focusing on the low air loss mattress, including its indications for use, its benefits, as well as how to properly set up the unit itself. This picture shows an example of a Braden scale in a slightly different layout than those we see in interior health, but with the categories and written portions remaining the same. As we can see, there are 6 categories of assessment on this form. These categories include sensory perception, moisture, activity, mobility, nutrition, and friction and shear. Beside these categories are the guidelines in which we compare and assess our clients to give them a number representing their risk for skin breakdown. We will now go through each category and highlight some of the interventions that can be done if that particular score puts them at risk. These interventions are taken directly from a guideline developed by the BC Provincial Nursing Skin and Wound Committee in collaboration with wound clinicians. Our first category is sensory perception. For this category, we will use the example of the diabetic. As we know, peripheral vascular disease in diabetics often leads to a loss of sensation on the extremities of these patients. You come into the patient's room and notice that their heels are red. You ask them if they're feeling any pain at the site and they respond with, "No, I haven't been able to feel much in my feet for the past few years. My doctor says it's because of my diabetes." On the Braden scale under sensory perception, their score would be a 3, limits ability to feel pain or discomfort in one or two extremities. Some interventions listed in the guideline for patients who score a 3 or less are as follows. Elevate heels off the surface of the bed at all times, even when using a therapeutic support surface. Use pillows, therapeutic pressure offloading devices, or devices especially designed for the client. Support the knees to avoid hyperextension when heels are elevated. Heel elevation in bed is especially important for clients with diabetes mellitus, peripheral vascular disease, neuropathy, and during and following surgery. Do not use rolled blankets, towels, pillowcases, incontinent pads, or IV bags to elevate heels. Heel protectors provide protection from friction and shear, but not from pressure, as they do not elevate the heels off of the bed. We can now move on to our next subcategory, moisture. For this category, we will use the example of a paraplegic who is incontinent and unable to perform self-care. This patient has come to the surgical floor after having his appendix removed. He is currently wearing a condom catheter which periodically leaks. He wears a brief to manage his incontinence of stool. He is finding that his brief isn't being changed as frequently as his care provider does at home. You notice his skin is becoming irritated and red on his sacrum. When you are filling in his Braden scale, you determine that he is a 2 under the moisture category, as his skin is often but not always moist and his linen must be changed at least once per shift. When we refer to the guidelines, some of the examples for interventions for a patient scoring a 2 are as follows.
That's good.
Avoid using incontinent briefs and pads unless client cannot toilet successfully. If using briefs or pads, check them with every repositioning or every 4 hours if the client positions independently, and change when soiled or wet. Gently cleanse skin folds and perineal area after each incontinent episode with a no-rinse pH balanced skin cleanser, and pat dry when finished. Do not rub the skin. Apply a skin protectant barrier cream product to protect skin from urine, feces, and perspiration. Protect sacral or perineal wounds from feces and infected urine. Use a fecal collector bag, condom catheter, or indwelling catheter if appropriate for the client until the incontinence problem has been addressed. Consider use of a low air loss therapeutic support surface. Consult with an occupational therapist, physiotherapist, or wound clinician if assistance is needed to select or access a low air loss support surface. Moving on to the mobility and activity subcategories, we will use the example of a stroke patient on a medical floor. The patient experienced her CVA 2 weeks ago and has come a long way, but still experiences significant right-sided weakness. She attempted physio today with little success, so is currently remaining in bed for most of the day. She is able to use her left side to assist her with reaching for objects and eating. While assessing her using the Braden scale, you determine she is a 2 under the activity category, as well as the mobility category. While looking at the guidelines, we can see some interventions that would be beneficial for this client. Here are some examples. The client is to be repositioned every 2 to 4 hours using either a full turn or small shift in position. For clients who are side-lying, use foam wedges or pillows to support a lateral position with a 15 to 30 degree tilt, and place a pillow between the ankles and knees to avoid contact between these bony prominences. Instruct the chair-bound client to shift weight every 15 minutes if the client can move independently in their chair. Provide clients with devices that will enable independent positioning and transfers, such as trapeze bars, transfer boards, and bed rails. Consult with a physiotherapist or occupational therapist if required. Inspect the skin for any new or additional damage each time the client is repositioned, toileted, or assisted with ADLs. For the nutrition subcategory, we will use the example of a woman who has been admitted to the medical floor with a bowel obstruction. She has been vomiting excessively over the past 5 days and has not been eating or drinking anything. Prior to the obstruction, her husband states she was rarely eating a quarter of her meals. Her bowel obstruction was clear today, and you're now assessing her nutrition. You determine she scores a 2. Below are a few examples of interventions in the guideline. Maximize the client's nutritional status through adequate protein and calorie intake, especially with stage 3 and 4 ulcers, if compatible with goals of care. Encourage 1,500 to 2,000 ml of fluid daily, or greater than or equal to 30 ml of fluid per kilogram of body weight. Offer fluids every 2 hours for adult clients with dehydration, fever, vomiting, profuse sweating, diarrhea, or heavily draining wounds unless contraindicated. For clients who score 2 or less out of 4 and have a non-healing stage 3 or 4 ulcer, consult with a dietitian if available. For this category of friction and shear, we will be using an elderly man with slightly limited mobility and decreased strength as our example. When he moves to get off the bed, he slides over the bed surface. While he's sitting in his chair, you notice he is constantly sliding down and boosting himself up. You note on his Braden scale that he is scoring a 2. According to the guidelines, these are some of the appropriate interventions for this man. When sitting, ensure the client's feet are supported directly on the floor on a footstool or a footrest so that the hips and knees are at 90 degrees to prevent sliding down in the chair. If the resident is sitting in a tilting wheelchair, then use the tilt feature regularly to alleviate pressure. The chair must be tilted at 30 degrees to alleviate pressure over the sitting surface. Consult with an occupational therapist for a tilt schedule as necessary. Elevate the head of the bed if this is appropriate for specific clients. Consider the use of patient handling equipment such as positioning slings with ceiling lifts to avoid shear and friction when repositioning. Use products such as elbow and heel protectors to minimize contact between the skin and bed linen. Synthetic sheepskin does not reduce friction or shear. In this video, I will be giving a brief overview of the low air loss mattress, including when it should be used, what its functions are, and how it works. I will then provide instruction on how to properly set up the device and how to use the tools that come with it. This is what your typical low air loss mattress looks like. We typically see them locally under the brand of KCI or Roho. You will often see these mattresses being used for patients who are prone to pressure ulcers or who have existing wounds. They can also be used for pain management. The low air loss mattress uses air pressure technology to increase blood flow to areas of the body that can often become dependent on patients who spend most of their time in bed. When you look at the mattress, you can see that there are rows of air chambers. These are called cells or bladders. While the patient is lying in bed, these cells rotate in inflating and deflating to allow for a constant change in pressure over the skin's surface. The material used is moisture wicking, which enhances wound healing and prevents ulcer formation by keeping the skin dry. The cells have minute airflow holes which prevent heat from building up and reduce the amount of moisture that the patient produces. We will now look at how to assemble and properly set up a low air loss mattress. Most systems come with an air pump, which also functions as the control unit, a mattress pad, the air mattress itself, which comes deflated, the hose which connects the bed to the pump, and a protective cover for the mattress. For the purpose of this instructional video, we will discuss how to assemble the Rojo mattress. Although it may have some differing aspects than the other beds, the principles of setup will remain the same. These mattresses function as a separate unit than the existing mattress on the bed. Therefore, the existing mattress must be removed prior to setting up the low air loss mattress. First, place the protective mattress cover over the bed so that the air hole which the pump will attach to is at the foot of the bed. In the picture provided, the protective cover is the shell that is partially over the mattress. In this first step, only the cover will lie on the frame. Referring to the picture again, we are able to see the placement of the air hole in which the hose is attached to. Open up the protective cover at one side with the allocated zipper. Place the mattress pad inside of the cover. It should lie flat and fit easily in the bottom. Before placing the air mattress inside of the cover, ensure that the 4 bolster straps on the air mattress are secured by fastening the Velcro. Although the picture provided is blurry, you can see these straps on the sides of the mattress as an example. You can now place the air mattress inside of the protective cover on top of the mattress pad. This picture also accurately depicts what this step should look like. Ensure the air pump connector is at the foot of the bed on the same side where the protective cover air hole is placed. Place the air mattress pump connector hole through the hole that is on the protective cover. Once you feel the air mattress is correctly placed, zip up the protective cover. Once this is complete, make sure you secure the mattress to the bed frame with the safety straps on the bottom part of the protective cover. Note that our air mattress is still deflated and will not look like this picture until inflated. We can now move on to setting up the air pump and control unit. Place the pump over the footboard using the given handle. Take the hose and attach it to the hole on the pump. Turn it until the latch clicks and the hose feels secure. Now, place the other end of the hose into the hole in the mattress at the foot of the bed. Ensure that the power entry switch is off and firmly place the power cord into the unit. This should be on the side of the unit underneath the power entry switch. Plug the other end of the power cord into a grounded wall receptacle and switch the entry switch on. On the control unit, push the button so it reads on. This button is directly below where it reads CPR on the unit. Once this button is on, the mattress should begin to inflate. Allow the mattress to fully inflate before transferring the patient onto the bed or switching any controls. Before placing the patient onto the bed, ensure the bed rails are up for safety and press the firm button on the panel. This button is located to the right of the on button. Place the patient centered on the bed. Use the weight chart given to assess which setting the comfort level should be at. This comfort level dictates the softness or firmness of the mattress. For example, a 100-pound person should be on the comfort level 4. This is displayed at the top of the unit with a number scale. Once the patient is on the mattress, make sure they are immersed 40 to 50%. If they are not, adjust the comfort level to reflect this percentage. Once this is complete, place your hand under the mattress to ensure adequate clearance of the patient to the bed frame. There should always be 3 to 4 inches of clearance and the patient should never be touching the frame.